Okay, good evening, everyone, or good morning, or good day, depending on what time it is where you are. Welcome to our webinar on cardiopulmonary resuscitation in low resource settings. I will try to let everyone in while I'm speaking. I will try my best. Please mute yourselves so we don't have any background noise, and then we can start with our webinar. I will give a quick introduction, and then we will have a panel discussion with our experts from low resource settings on the topic. My name is Sebastian Schnaubert. I'm one of the authors of the recent ILCOR statement on the topic, and together with my colleagues, we will guide you through this webinar today. So for a quick overview, why are we discussing this, and why are we discussing this now? This is a big question, of course. Well, there's been some concerns, I would say, that science recommendations and also the ground science, I would say, about resuscitation and everything around it comes from high resource settings. So, for example, from Europe, from the US, from, I don't know, Australia. And maybe if you read the recommendations, if you read the guidelines, you could get the impression that those recommendations, those guidelines are also aimed at high resource settings. And this then leads to a questionable, I would say, at least questionable applicability in low resource settings. So what are low resource settings? This is also something we have discussed in the statement, and we will discuss later on in more detail. This can, of course, mean money, funding. You don't have enough funding for things, but this can also mean low resource settings in terms of I'm in a remote area. I don't have all the resources available that are mentioned, for example, in the advanced life support guidelines. For example, if you look at this picture in a highly mountainous area, you won't have an ECMO available within 10 minutes, of course. So this would also classify as a low resource setting. And then very quickly, one could, of course, discuss this very lengthy also. If you think about this, you have low and middle income countries as defined by the World Bank, for example, or, well, there are many definitions. And then you have high income countries. And then parallel to this, you have those low resource settings and high resource settings. And then it's quite intuitive to say, well, a low income country will have low resource settings, and then the applicability of these guidelines and recommendations is not given there. But as I've mentioned, for example, you have a very high income country, for example, Austria, where I'm from. And then you have, well, a highly densely populated area like Vienna, the capital. And then there you have all the resources you can think of and that you can wish for. But then you have also the Alps, a highly mountainous area. And then there you have a low resource setting. You don't have everything available within 10 minutes. And this leads to a variability of resource scarcity also. And this is also something we will discuss today. This has been one of the first, well, official, I would call it, suggestions or protests against guidelines, recommendations coming from high resource settings, and then just, published and saying, well, this is everything you have to do in resuscitation, around the resuscitation. This has been a letter to the editor saying, well, ILCOR is not doing its best, and ILCOR has neglected this issue in the past. And as a kind of reaction to that, we have formed a task force, a working group within the EIT task force of ILCOR. My colleague will talk about this in more detail in a moment. And then we, put together this recent statement that has been published in the Lancet Global Health. This is, the issue front cover, you can see on the left-hand side. On the right-hand side, you see the title of this statement. We won't go through the statement in detail. This would take too much time. I recommend to read it, but we will discuss the surroundings of it today. And you can also see that this statement was supported by several organizations, like, also variability there, European organizations, African ones, etc., international ones. So we try to have, a diversity of resource settings in the organizations supporting the statement, but also in the author group having written this statement. This is something, a bit of an overview of the statement. You can see here the main points we tried to address. We wanted to, create some awareness that resource settings are in fact dynamic, as I've mentioned before. This ranges from, money problems, funding problems, all the way to geographical issues. Then we also addressed the issue that most CPR recommendations as of today only address, high resource settings, are written for high resource settings, and are probably mostly applicable to high resource settings. We have tried to put together a working group, a writing group of international collaborators coming from all kinds of resource settings. This hasn't been optimal, of course, and we will try to optimize this in the future and have even more diversity in our working groups, writing groups. We have stressed we've really stressed that a more inclusive view in the future is needed on this, and that we need to involve people from all kinds of resource settings in the development of guidelines. If we say this is truly international and this is a guideline, a recommendation that we want to publish for everyone. We have acknowledged existing systems. There are, of course, we are not the first ones addressing resuscitation or emergency medicine. There is, of course, a program by the WHO. There's first aid chapters, guidelines by the Red Cross and Red Crescents. There's the Helping Babies Breathe program, of course, focusing on children, babies. But they also have resuscitation in their guidelines, in their documents. But ILCOR, of course, focuses solely on cardiopulmonary resuscitation. Then we have suggested the chain mail of survival, not instead of the chain of survival that you all may know, but as an addition to the chain of survival. The chain mail, I will talk about this in a moment, is one of those steps we try to take to have a more inclusive view of this in the future, but more about this in a second. We have addressed certain enablers, barriers, knowledge gaps of and about the problem. We've listed those that were, mostly coming from the experts of, from low resource settings in the statement. You can read them there. And we try to formulate action points. Those action points are just first preliminary ones, of course, but, points that could be addressed in all kinds of resource settings. This is the chain mail of survival I've just mentioned. This is, if you look, at the very thick pieces of the chain mail, this is the chain of survival, and then hanging from it, this is the chain mail of survival. And you can see there are many, many parts of it, linked together, and together they form the chain mail of survival. So if one chain link is broken, then not the whole chain mail falls apart, as it would be the case with the chain of survival, but it still protects, the cause. And this is the general idea of that. You can read this in detail at, when you read the statement. This is just an example. We won't go into detail here, but this is just an example of what we proposed. For example, essential resources to be implemented. Well, basic resources that you should have, advanced resources that you should have when you think about resuscitation. What are the plans for the future? This has been a statement, a preliminary statement, a first statement, not based on a systematic, evidence approach. So this means, of course, that we are planning a second, larger ILCOR statement that will be based on a systematic literature review, and it will, coming from different experts and also from various subspecialties like pediatric resuscitation, adult advanced life support, and so on and so on. And we will try to address all these links of the chainmail of survival, in the light of the low resource settings, together with the experts. And this is something I really liked. This is from the Helping Babies Breathe program. They say that simplicity and clarity open the door for change. Facility-based education in knowledge and skills initiates change. Mentoring and empowerment of health workers solidify change. Monitoring, data collection, and use of data to improve care supports continued change. And this is something that we could also aim for resuscitation in low resource settings. If we want to change something, if we want to have guidelines, recommendations that are truly applicable to all kinds of resource settings, and we should look at this statement, I think, and try to, implement it. So what we could achieve with the second statement and all the work coming from there and developing from there, of course, are recommendations that are tailored to your resource settings, education programs that could be tailored to your resource settings. And we could, with that, try to trigger and empower local adaptations of guidelines, of recommendations that would then lead to more lives saved, also in lower resource settings. This is a global approach, and the more people from all kinds of various resource settings work together, the better. And this is why we're also hosting this webinar today, to have a communication, have a discussion about this, and hear from the experts from the low resource settings what their views, their recommendations on this are. We will have a panel discussion in a moment. Before that, I would like to invite two people to give their thoughts on this. The first one is Tino Greif. He's the chair of the IT task force of ILCOR. And then the second one is Koen Monsieurs. He's chair of the ERC. So Tino, maybe you can give your thoughts briefly, and then we will continue.
So I'm here in my function as the ILCOR task force chair for education implementation and team. As said before, the task force did a scoping review for the 2020 consensus on science and treatment recommendation from ILCOR, and the evidence was rather weak, which means there are not really randomized controlled trials looking what is going on resuscitation in low resource settings. And as a result of discussions, the task force decided to make a statement. And this, I would like to explain this. What ILCOR is doing, ILCOR is looking at scientific evidence for what happens in resuscitation. So what is the evidence for a drug, for a procedure, for an implementation tool? And out of this evidence, which is then published as consensus of science and treatment recommendation, local, regional resuscitation councils make the guidelines. The Americans, Europeans, Asia, Australia, wherever they are. And the task force, if there's not such solid evidence, ILCOR and also the task forces can make a statement which is more a global view on a topic, and this was, in this case, low resource settings. And therefore, a first statement was issued. I'm not sure if we really ILCOR can do a recommendation on how to do resuscitation in low resource settings, because a recommendation is always based on solid science, which means randomized controlled trials. What we can do as a result of the discussion and the evidence we will find, which are mostly of observational studies or reports simply, is a guidance, like a good clinical statement, how to do it. Because the science of resuscitation, so how we are doing resuscitation, is in all areas of the world the same. So the physiology of humans is pretty the same. So you have to do chest compression, ventilate, and providing defibrillation. What changes with different settings is the application of what should be done, the implementation locally, and the system. So we are overall looking at the big picture of what should be done and how can we apply this locally. And that's what we want to do with this upcoming statement on a global level. So ILCOR opens the door. We want that people from whatever setting is coming in, tells us what are the ideas, how the big picture of resuscitation, the applied physiology can be implemented in different local settings with the structure they have at their places. And that's what should result in the end in such a statement. So we have a scientific approach, we look at literature, but we will also include the experience from different areas. And this is all on the system level and local implementation. The plan is to have this hopefully by the end of 24. And why, from the ILCOR perspective, I'm looking at end of 24, because if we have such a statement, this can be integrated in the upcoming guidelines worldwide 2025. So this is from my point of view, from the ILCOR point of view, what I would like as an introductory statement. Thanks, Sebastian.
Thank you very much, Tino. So we will move on to Kuhn, your thoughts from the ERC perspective, please.
Thank you, Sebastian. Before I go into the importance for the ERC of this statement, I'd like to tell you a short story first, because when I became the chair of the ERC, which is now over 2 years, more than 2 years, people were asking me, how can I get into the ERC? What do I have to do to get into a working group or a board, the board of the ERC? And it is true that the board of the ERC at that time was composed of mainly male, Caucasian, white male. And I thought, well, indeed, there is a problem. So how do you get into the board of the ERC? And today, still, the board of the ERC is completely white male. So the problem is still there. There was a group, and there still is a group, which we call the diversity group, also to look into the problem why the board of the ERC was full of white male. And the diversity group was full of female, which is maybe also not, not ideal, because it is not very diverse, but it is a start. And this group, this diversity group, slowly built into a group, and it hasn't finished yet, and it is now a group we like to call diversity, equity, and inclusion, because that is what it is about. It is about participation. participation in the ERC, participation in the board of the ERC, or participation in the working groups of the ERC. The working groups we now call the Science and Education Committees. And when the Science and Education Committees were renewed some 2 years ago, we made it such that the chairs, there's always 2 chairs of each of these committees, are composed of 50% male and 50% female. So at least that is the start of gender diversity and inclusion of other people than male. And also the members of these committees, we try to make them diverse in terms of gender, in terms of region they came from. But still, it is all within Europe because we are the European Resuscitation Council. But our guidelines are also used outside of Europe, not to say worldwide. So it is important that our guidelines are diverse. And in order to become diverse, they need to include situations that are not high income, high resource. But the question is, of course, how do you get there? Because in order to write something about the situation which is not yours, because I live in Belgium, and Belgium is what they call a high resource country. So in order to move from this situation of a high resource perspective to another perspective, a more global perspective, we need to talk to people who come from these areas, who live there and who know, because I don't know what is happening in situations that are different from mine. So this is what it is about. It's partly, it's partly a bigger problem about inclusiveness, but we are committed in the ERC to at least address this. So I'm very happy that ILCOR also now leads by example. But the ERC is committed to follow the example of ILCOR. So as Tino says, in the next ILCOR recommendations in 2024, 2025, and in the next ERC guidelines, there needs to be at least a paragraph from another perspective than only the high resource settings perspective. It is as pediatricians, and I'm sure there are pediatricians on this call. It's like pediatricians say, don't forget the pediatric paragraph. So from this example of the pediatricians, I would say, let's not forget the other than high resource perspective, and it should become or be more than just a paragraph. I don't know how exactly we will achieve this and how far we can achieve this by 2025, but at least I'm hoping that this is a good start, and I'm hoping that we can receive a lot of information now from our colleagues on this call, the co-authors of the statement and the participants, who can give us another perspective than the one that we are used to for so many years. So thank you, Sebastian, for leading this, and I'm looking very much forward to further discussion. Thank you.
Thank you very much, Koen. We are very fortunate to have one of the supporting organizations here on the call today. This is AFEM, the African Federation of Emergency Medicine. I think this is Rob, if I'm not mistaken.
Yes, hello everybody.
Hey, so in your dual function, I would say you're from I don't want to presume your resource setting, but I would presume that you are not always working in high resource settings, maybe, and you're also representing AFEM today. Maybe you can give us your view on this statement, on what we've discussed so far. What's your opinion coming from AFEM?
I would love to, but I would feel that probably my colleague, Dr. Ratimi, who I'm just now searching to see if he is on the call with us, would be far better placed to do so. Rotimi, are you on the call at all?
Of course, if they're here, that's also possible.
Yes, Rob, I'm here. Hi, how's it?
All right.
Go ahead, Rotimi. The floor is yours.
Okay. Thanks, Rob. Thanks, Sebastian, and thanks everybody who is on the call. Thanks for the opportunity. I think just speaking as from AFEM's point of view, really appreciate this opportunity and this initiative to bring together people from different resources. It's been quite an issue considering the different resource settings we have on the continent and the attempt by all these different member countries to follow guidelines that have shown evidence in high resource settings. But the challenge, as all the speakers have said, is that in low resource or lower resource countries, the priorities are slightly different. Definitely the goal is to preserve life, to make sure that the chain of survival is maintained, but there are various things at various levels which become priorities in all these areas. And the discussion is, I think, definitely the first step for us to have guidelines from these other resource settings such that they can have a buy-in, a say on what happens, maybe generally starting with saying these are the things and the challenges they have, and then trying to now find a way to implement some of these guidelines in a way that would give the best result in their settings, in our settings, and such that we won't feel that we're missing out on the evidence that has been gathered from other resources. I think, like you said, we need to hear from all the resource settings and get an idea and a picture of the things that are focused, are the focus and priority for them. We as IFEM as a body definitely will support whatever process ILCOR goes through to get guidelines that would reflect the practice in many of the low resource settings. We're eagerly looking forward to this opportunity. Hopefully we'll be able to put hands together with all the representatives from various settings to be able to get a better idea and a better understanding of what the priorities for all these settings are. Thank you again for the opportunity, and I hope we can get more things to work together and to bring out evidence. And I like what Tinu said about these guidelines are based on evidence. I think it's time that many of our low resource settings bring out the evidence that they have, and we find a way to get the best quality evidence from these settings such that we can now apply them to things that ILCOR is putting out in their guidelines. Thank you very much.
Thank you. Thank you for your thoughts. Maybe you can mute yourself again. Perfect. So I think you've touched a very important topic here. So this question goes out to all those people considering themselves working in low resource settings. What do you think is your current, well, what are the possibilities of your involvement in guideline or recommendation processes? Do you think that these processes should be adapted to, allow for more involvement for people from low resource settings, or what would you wish for in this aspect? So maybe does someone have any thoughts on that? I've also seen some of the co-authors of the statement on the call. So anyone having thoughts on that? Maybe one of the co-authors. I've seen Mahmoud, Huba.
Sebastian, this is Sanjay.
Hey, yeah.
Well, can I talk for a while? Is
Yes,
it okay?
please.
From the okay, actually, I'm so glad to understand about the discussions and all. So the thing is, I much agreed with Cohen and his uh, point of views and all. But here, actually, if we talk from the low resources setting, actually, what I can say is the low resources setting, or we can say that low resources country, also there are variables. For instance, in the low resources country, there are some hospitals or some places where we have a high advanced setup, as well as in some particular places, actually, it's really, really low and we can say directly that it's totally underdeveloped. So thing is, how do we balance that is a big challenge for the low resources countries or low resources places. The important thing that I realize from my perspective is the the training and another important thing, very important thing that I can address here is the refreshers training, because here in our place also we have various organizations, they are training the people, or even in the hospital, even from the hospital shelves, or from other organizations, they are giving the training, as well as people are trying to uh, acknowledge the guideline, or they want to practice the guideline. But the problem is, the where problem arises is about the refreshers training. For example, like today, if I get a training and I will be more enthusiastic that okay, from tomorrow onward uh, I'm gonna follow the same guideline, or I'll do my best or something like that. But after few days, a few months down the line, that will be vanished, and there is no harmony among the people here. For instance, if I be active enough to follow the guideline, maybe my another colleague may not be. So these are the basic challenges that that we face here, especially in our country. Here in our country, few places or few uh, advanced setups are there where European Americans, how they do, we do in an equivalent way. It's really, really admirable. But if we go a little bit far away from here, or from the major city, then there is actually, we can say there is zero. There is, we cannot provide the proper medications, and the people, they cannot follow the guideline very properly. It is maybe because of, one is definitely the financial thing. For instance, the people who goes to the remote areas are not getting enough remunerations. That is the reason why the people, the knowledgeable people, they are not willing to go to the remote areas. And another thing is, people, they are afraid of losing their skill if they go to the this low resources setups in our country. I think for that, number one thing, I'm actually really happy to understand about the diversity stated by Cohen, that from the low resources countries also, there must be a representative in the organizations, like for instance, yeah, ERC, that is for the European, but still there should be another some kind of organizations where there should be a diversity, and the people really from the low resources setups should be there to raise the voice in the major platforms. That is what actually I feel. Thank you, Sebastian.
Thank you very much. You're working in Nepal. Maybe you can just give us some thoughts on what parts of the guidelines are, well, is it like that the more advanced the guidelines get, advanced life support, I don't know, ECMO, blah, 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 well, the more difficult it becomes to follow them? Or is it also that you say also in the BLS guidelines, also in first aid suggestions, also there are points that we need to address, that we need to tailor for low resource settings? Or is it just the advanced steps?
Okay. Thank you for the question. Actually, that is also, it depends. For example, when we talk about the ECMO, yeah, there are some advanced setups in Nepal where we have ECMO facilities. The place where I currently work at the moment, we have ECMO. Any patient coming and who needs ECMO, actually we can easily cannulate the patient. Yeah, but there are places, but the majority of the places we do not people they do not even heard about the instrument called ECMO. Yeah, and even in terms of BLS, yeah, the place where we work, there are thousands of people are working, and all of them are most of them. I mean, we can say that more than 90% of the staffs here in our setup, they are BLS trained. Yeah, but the thing is, if we go to the low resources place of our country itself, then people may not heard about this. Yeah, if they heard, but still they are not trained. So that is the variabilities. Actually, there is a distinct between the place of advanced setup and low resources settings, even in the country which is considered as a low setting. So BLS, ECMO. As I said, ECMO is there, but the thing is, there are some places, well, even the BLS protocols or guidelines are not being followed properly. That is the reality, actually.
All right, very interesting. Thank you. We have touched a bit the topic of regional councils. ILCOR is, giving international, we call it, but we're challenging this a bit now, recommendations. And then the regional resuscitation councils, usually translate this into their own guidelines. So maybe we have Huba in the call, who is a co-author of the statement. Maybe you could give us your thoughts on this. How do you think the regional councils should work into this, the translation of the, maybe international, maybe very general suggestions, recommendations into regional guidelines? Huba, can you hear us?
Yeah, I can hear you. Thank you very much, Sebastian, for the opportunity. And it's always great to work with the ILCOR team. So the regional one would be basically the one who are feeding the international guidelines by how the guidelines are contextually relevant. So in low resource setting, when we are using the guidelines from the high countries, we basically modify them in our context. And those are the things which from the every region can share at the international level, and then international level can guide us. The guidelines can guide us whether we are going in the right direction or not. And scientifically, even for the implementation part, developing a guidelines or regional partners should be the part of the developing the guidelines as we develop the chain mail diagram that is far more in detail, talking about what should be the community CPR look like, what should be the telephone CPR look like, or there is a role of bystander CPR, there is a role of a CPR in the school program. So these are all the things which doesn't require a lot of resources in a low resource setting, but that could be feeding from the region level to the international level. So I do believe that international guidelines should before every region had different dynamics and every region have different environment. So it's very important that the literature, whatever the literature or whatever the science is coming from to the international levels should be coming from the regions where they have the not only the scientific experience, like Robert said that scientific comes from the RCTs, but the experience of the people over there is very important, because research is all about experiencing and looking for the experiences of the people. So those are the things which are really, really contextually relevant and changes the guidelines at the international level. And that from the international level, the implementation would be easier as compared to the region level. I think the need assessment, contextuality of the guidelines from the region is a very important thing which can feed the international guidelines, and they are the one who implement it. Because in the low resource setting, when we are working, we always look at what are what is the new guidelines for AHA? What is the new guidelines for 2005? It's every 5 years there is a new guidelines which came in. But when we come to the point where Sanjay said that there are facilities which have ECMO, so when we are teaching our students or we are teaching our communities, we said that these are the things which happen in the high resource country, but because we are low resource and we are resource constrained, we will stop over here. So that should not be the thing, because for the life saving you don't need a lot of you need a lot of resources, but initial recognition, standardization of the practices is very important. So I agree with the point that regions should be incorporated, regional thoughts, regional brainstorming brains should be there in feeding the international guidelines. So these are my 2 cents. I hope I answered the question.
Yes, perfect. Thank you. I just like to mention, if anyone has a question, please raise your hands. Federico, who is monitoring this, will then notify me. I think Mahmoud tried to say something before. Mahmoud?
Yeah, thank you for this opportunity. Also, I'm very glad to be with this distinguished group. I am Mahmoud. I am from Sudan. I just same like Kon, I would like to tell a story. I'm working in 2006 in United Arab Emirates, and it is high resource setting, as you know. So I became an instructor in ERC courses. So I think about why I'm taking this course to my home country, Sudan. So when we start in 2008, our first course in BLS in Sudan, there is no any international course, even there is no local courses, and the people, even most of the hospitals, there is no defibrillators at that time, although there is many medical schools. So we reach up to, we have a full faculty for all ERC courses, and in 2013, so now in October 2013, we have an agreement with the ERC. We become a member of the General Assembly of the ERC. ERC is accepting. So this is one side of the diversity. And when I remember in one pilot course, we did it in 2016 in Sudan Medical Specialization Board, led by Casting and Joachim. And Joachim, he gave a good presentation about the ILS and ALS and how can be adaptable to the low resource setting for and at that time, most of the audience are the residents in surgery, emergency medicine. At that time, this is the first batch of emergency medicine. And believe me, the ERC courses in Sudan is now changing all the environment in emergency service, especially in the capital Khartoum, and even in some of the medical colleges. And to the degree that it is now mandatory to register for the Sudan Medical Council to have a BLS course to be registered as a nurse or as a doctor. And even the program of the emergency resident program started in 2016. This year we graduated the 5th batch of the emergency physician, and the entrance exam for the first year, depending on the on a course called sales course. All the guidelines came from the EPALS, ALS, and European trauma course, and the BLS course. It is a 7 days course. You need to pass this course to have to enter from R1 to R2, and now there is a local courses, and they have some medical schools, some universities are adapting the local the international courses of the ERC, and our group now became an international instructor in the ERC, participating even in courses outside Sudan. And I echo also Tino that if the AFIM take this opportunity on board, and in the next conference in 2014 in Botswana, it will be the main theme to address the CBR or resuscitation in low resource setting. Because in 2019 also we have a mission from the ERC to start the ALS courses in Kampala in Uganda. And after that I visited Uganda for 6 times. Last June, we did an EPALS, ALS course, ILS course, and even neonatal life support course, plus generic instructor course. And we found that there is a political will. By the end of the courses, all the Minister of Health and the Secretary of the Minister of Health, all the CEOs of major hospitals, they have a meeting. They invited us to talk about the courses and how they can link with the ERC courses. I found that because here in United Arab Emirates, for example, there is diversity of courses, AHA and ERC courses. ERC courses is more modular and can adapt in the low resource setting, and even the cost effective for the courses. I think because the ERC implementing the Kaula factors, cost of living adjustment, and this helped us in Sudan because the payment of the doctors and nurses, even they cannot cover the cost of an advanced course. So I think to have a guidelines to take this on board by the AFIM, I think it will help a lot in the developing a guidelines can be adaptable to the local resources. Thank you.
Thank you, Mahmoud, for this positive example. We don't only have negative examples or well, problems to talk about. We also have positive stories to talk about. Thank you for that. Fred Mboya has raised their hand. You have a question?
Hello. Hello.
We can hear you, yeah.
Okay, my name is Fred Mboya. I am a recent graduate from medical school from the University of Nairobi in Kenya. So from the student perspective, I happened to have volunteered to teach skills in BLS and ACLS among fellow students, having been trained by an organization in our country. I personally think the challenge is more about low levels of awareness, and I think this has been coupled by the fact that skills in BLS and ACLS are not incorporated in most, if not all, of the universities as a requirement for graduation. So I think when this kind of gap is brought into light, I think a lot can be addressed with these. And also, probably I'll recommend the African Emergency Organization to probably work with different medical institutions to kind of advocate for increased or rather integration of emergency skills into the curriculum. So I think with increased awareness of the same amongst medical students, then probably policies might come up, and this could help address some of the challenges I think that most of our setup are experiencing. Yeah, so thank you.
Thank you very much for this. So the importance of the academic institutions. Lauren from AFIM has something to say to that, I think. You raised your hand.
Hi, Sebastian. Thanks so much for this webinar and for the opportunity to have a wide range of perspectives shared. It is so encouraging to hear that there is interest to have AFIM be involved, both from ERC, but a number of the guests and speakers on this call. Maybe just to give a little bit of context and background in terms of what AFIM has been doing around how best to contextualize for particular low resource settings. And we, of course, we appreciate the scientific robustness in the process that needs to be completed in order to generate guidelines and global recommendations. And we fully support that, as has been articulated by Rotimi a little bit earlier. And so we fully are committed to this process. In parallel, what we have done in terms of contextualizing practice is we understand from settings that are not as mature in terms of their emergency system preparedness and readiness, in low resource settings, particularly within Africa, where emergency care and emergency medicine in itself is not yet a mature discipline or specialty. We understand that from a health systems perspective, and certainly from patient outcomes and even a cost effectiveness point of view, that many of the interventions require that we preempt the condition of cardiac arrest. And so many of the approaches that we take is to try and identify early in the clinical course areas for critical intervention that will preempt and hopefully avoid the situation of cardiac arrest, given the outcomes that have been reported from out of hospital cardiac arrest. To this end, we have then worked quite committed. We've been very committed and quite deliberate in our approach to, while also supporting advanced life support interventions, basic life support interventions as per ERC and AHA. We also offer training and opportunities for basic emergency care. Basic emergency care does not incorporate CPR and actually tries to preempt the condition of cardiac arrest so that conditions are identified rapidly and interventions are initiated that are easily available within low resource settings and within a constrained human resource environment as well, but still offer the ability to provide high quality basic emergency care with the hope that there is at some point a modifiable element and that the unfortunate outcome of cardiac arrest may never have to arise. And that is how we have adjusted to contextualizing for our particular context.
All right, thank you for giving us this important piece of background information on that. I've seen in the chat that Sarah has something to say about the, challenges in training. Sarah, are you still here on the call? I think so.
Yes, Sebastian, I'm still here on the call.
Maybe you can elaborate on your thoughts on that.
Yeah, so the Good Samaritan law is only available in UAE and Lebanon, and Saudi Arabia and Morocco is en route to have it implemented, and hopefully more Arab countries will do so. So people are reluctant really to offer help and to support any casualty or accident that might happen on the road. Though many are trained or they have some knowledge or they know the emergency number, and they can do some basic help to the casualty. However, they are reluctant. They are afraid from being questioned, from being, illegal action will be taken against them. So unfortunately, this is an issue. However, we are working with key players and individuals and thought leaders and government officials to push for Good Samaritan law in these countries. I was fortunate to help in the Good Samaritan law implementation in UAE and Lebanon when I was working for the American Heart Association. And hopefully the one in Saudi Arabia also, we are working closely with the Ministry of Health to have this implemented. Like I said, the community are eager. They love to help. They would love to help, and they are trained. But this is an issue. Having this statement on low resource countries and settings will definitely help in the government in looking at this, at having more, what shall I say, be creative in opening and offering more training, different training available for the community, not only for healthcare, but also for the community through the Red Crescent or international bodies like ERC and AHA. hopefully this will help encourage people to offer the training, even if there is no Good Samaritan law implemented in their countries, because the government has put some guidance or some support to them. We hope, and because it did help in some of the countries, but like I said, in most of the countries, people are very reluctant to do so. So in our training, we always encourage people to learn and spread the awareness how to save people's life, regardless if there is a Good Samaritan law in their countries or there isn't. There is or there isn't, until a day that it will be available. In the meanwhile, they can call the emergency number, they can do some help and assistance to the casualty until ambulance and emergency services will arrive. So that's what I would like to say. Thank you.
Yes, I think this is very interesting. Maybe you could also say that also political support, also the presence of, for example, the Good Samaritan law, this could also be some kind of a resource. So countries not having this could also be classified as low resource settings in this, well, kind of political, law topic. So this is something with also already mentioned in the beginning, I think, that also high resource countries, high income countries can have regions or, well, parts that could be classified as low resource when it comes to resuscitation. In this regard, I would like to ask Peter Pahl, who is on the call today, not just because he's also a fellow Austrian, but because he's an expert in alpine medicine. What are your thoughts on this? What's your approach to resuscitation in low resource settings, which I'm sure that the highly mountainous area would be, as well as some other wilderness area. So what are your thoughts on this, Peter?
Yeah, so Austin, thank you very much for the invitation, and thank you for organizing this fantastic meeting. 3 points come to my mind for, let's say, low resource settings in high income countries. First of all is prevention of cardiac arrest. So we know that the outcome is much worse when cardiac arrest happens in a low resource area, also in a high income country, because the transport ways are much longer. There's less resources available on site. We know, for instance, that there are also less AEDs available. There are less people, or the likelihood of bystanders is lower if cardiac arrest happens. So therefore, prevention is very important. We try to train people in our areas to, let's say, start CPR early. So what we discussed before, training or even retraining. Also, let's say, mountaineers, if they go for ski touring or skiing, is very important, because we know that as soon as let's say people are buried by snow, they suffocate very quickly. Let's say the chances of survival are very low once they are below the snow for 10, 15 or more minutes. So the comrades have to try to get this person out of cardiac arrest in the first 10, 15 minutes out of the snow and perform BLS, and then the chances of outcome are very good. So this is the first thing. The second thing is we have to try to adapt also the guidelines from, let's say, from high quality urban studies with good RCTs to the mountain environment or remote environment, which means that, for instance, there is no chest compression, only CPR once you are distant half an hour or even more flight way from the next HEMS station. So you need to perform, and you have to train the people to perform ventilations. That's the second thing which comes to my mind. And third, also in, let's say, in these low resources, dangerous areas with you mentioned mountains, Sebastian, but it could also be dangerous terrain, cold or, let's say, polar night, let's say, areas. It's also important to protect the rescuers. So once you have performed 20 minutes of CPR in a normothermic patient, and you had no, let's say, no defibrillation recommended, or the AED, for instance, has never recommended defibrillation, and on the manual defibrillator you have never seen VF, and you had never had a return of vital signs, after 20 minutes, you should strongly consider to stop CPR and not to basically transport this patient out by upsiling or the other difficult techniques, because that may endanger the rescuers. But of course, also in these low resource settings in high income countries, these patients could be under special circumstances. So we have also to train our rescuers specifically for them in these high income countries, low resource areas. So these are 3 points I would like to make. So thank you very much.
Thank you, Peter. Well, obviously we all also have, well, in the, you mentioned the special circumstances. We also already have guidelines or recommendations on how to resuscitate people who are very, hypothermic or in an avalanche. You mentioned this. Kuhn, maybe you could answer to that. Is this maybe a possibility to, get the hook in and say, well, this is something where we can, well, adapt the guidelines more to low resource settings in high income countries, or in general low resource settings, or is this something we shouldn't go for in your opinion?
I'm not sure what the right approach is. I think what I heard and what I learned is that the low resource settings, for instance, in Nepal or in Sudan, we're not talking about special circumstances. We are talking about the standard CPR, which is probably where most of the people can be saved. But again, this is new. I don't know very much how to approach this. I'm feeling that we are still at the beginning of, even at the beginning of the discussion. The start probably is to build diverse teams, to be able to exchange this information and to talk more on a regular basis, not only on a webinar, but to create opportunities for meeting, and then we will find out what is important and what is not important. So I really cannot answer your question. Surely, in the special circumstances, there are some very interesting and important low resource settings that can happen everywhere. But I'm just not sure that would be our priority to tackle. I'm not sure. Can I, Sebastian, say two more things? One is I've heard about the maturity of the emergency medicine specialty in some countries. I'm thinking resuscitation is not only emergency medicine, but maybe most of us are engaged in emergency medicine, and that's why we are mentioning this. But even in Belgium, in emergency medicine, I would not call it a mature discipline, and we are certainly not the only country in Europe that where emergency medicine is still developing as a specialty. And when we speak about making ALS courses, PLS, trauma courses mandatory or a requirement to obtain the specialty degree, that is not even in a law in Belgium. We require it, and we expect it, but legally candidates could even fight this, so it's even when I look at my country, that most people would look at as a high resource country, Belgium, the specialty of emergency medicine is not mature. So the lack of maturity is not something from, is probably a global issue, more than an issue of certain parts of the world. And if I may, one last thing, maybe, and I see that the light in the environment I am is fading, but I hope you can still see or at least hear me. I'm wondering about the ERC conference, Mahmoud talked about the cost of living factor that the ERC is using for certification of courses, of ERC courses. So there is a cost of living that I think is a factor 5. Like in my country, it would be 100. So the cost of a certificate or a book would be 100. And in a low resource country or a low income country, it would be like 20, like 1/5 of the price. This is what we use as the ERC to hopefully make it more affordable for countries with less resources to also buy, manuals or maybe course certificates. I have the impression that it may not be enough. This is what I hear from those countries. They say, 1/5 of the price is still a lot of money for us. So it's still a lot of money. And then I think about the ERC conference that is now coming up for the next month in Barcelona. We don't apply cost of living. The price of attending conference is maybe 600 euros or maybe more as an entrance fee. Not to speak about cost of travel and of hotels, which is very expensive. So that could easily be a few thousand euros. And so I'm thinking, is this right? The conference is supposed to unite people to allow exchange of information, and then it seems to me that it is more, let me speak frankly, only for the rich, only for those who can afford it. So I just wanted to say this, that I'm puzzled about not just the cost of certificates or training, but also the cost of conferences. And I'm thinking, what can we do to be more inclusive than we currently are? Because the current conference, although a fantastic opportunity, is probably beyond reach of many colleagues. And I just don't know the answer right now, but I hope I'm seeing the problem, or at least I'm starting to see a problem, at least something I feel that is a problem. And maybe if someone wants to respond to this, I would be very happy to receive some guidance, some insight about this, because this is what I perceive as a problem right now.
Thank you, Koen, very much for your thoughts. Does anyone want to respond to this? If not, if you're still thinking on that, I have another question, because you also mentioned, Koen, that communication is key, and that we should, now after the statement and the development of the second statement and the webinar, etc., we also have a session at the Congress on this topic. Start to talk with each other, bring up problems, hear from colleagues working in these low resource settings. And then there's still the question of getting involved into the guideline process, into the recommendation making process, I would call it. Maybe Tino, can you maybe give your thoughts on this? What ILCOR should do about that in the future? Or, well, we have made a recommendation in our statement that maybe people from low resource settings should be invited at least to working groups. Maybe you could very quickly give your thoughts on that, Tino.
For ILCOR, for the different task forces in ILCOR, every year there's a call to become a member. There are certain criteria, obviously, for the scientific review process. There is the question for some competences, but 2 years ago, ILCOR started to open the door also for people who have not so much experience in doing systematic reviews. So there are mentee positions. You can apply for a mentee position and learn how this works. And then after 2 years, you might become then a full member of a task force. This is one way of participating in the science production, looking at systematic reviews and scoping reviews. For the ERC guidelines, what we plan is really what I would like for each of the chapters or sub-chapters, a little paragraph, how to do this, whatever it is, in low resource settings, if you can talk about this. I think when we start to address this, maybe in the 25 guidelines, we won't have the perfect answers, but it's a starting point. And then the next time it's more and more. And finding a way into, for example, the making of the ERC guidelines is in participating in the ERC simply. It's the local European guidelines for the Europeans or countries around Europe. And if there's a local resuscitation council, like Mahmoud said, from Sudan, we can then invite people working with us on these chapters. And over maybe it took quite a long to have a European Resuscitation Council, an Asian Resuscitation Council, Australia. Maybe sometimes in Africa there's a collaboration of different areas and they can formulate a kind of local resuscitation council and starting doing this. I don't see the way that the white guys from the North Hemisphere is going to tell all the other areas in the South how to do it. I think this should come from whatever area you are. You should do your stuff. And I mean, if you ask me, we can help, but at the end, it's your decision. The time of colonialism is over, I would say.
So you're stressing the importance of regional councils, of local initiatives, right? This a little bit falls in line with the question I got in the chat from Alice from Uganda. They ask if some conferences, workshops could be conducted in the future remotely by experts, champions in our countries, their countries.
Yeah.
This could be a solution, of course, to give support, to build something, build a structure in your regions. And is that right, Tino?
I'm not sure if this is a solution, but it's a first step.
And
as technology advances, we might have different ways in a couple of years. Who thought 3 years ago that we have a video call around the world like now? 5 years ago, it was not even thinkable.
Exactly, yeah. And I think it was very nice what Kuhn said, that he thinks or he hopes that he got the problem now. I think what we're trying to do, what we were trying to do with the first statement and also with the upcoming second statement, with all that activities that we're doing right now, is thinking about what is the problem and hearing from you guys what do you think the problem is. And I think this is the first step to a solution, if there is a solution. So I think this is very much still work in progress. And well, you and your opinions is really the main part to progress this further. Are there any more thoughts from anyone? Because the time has gone by very fast. Any questions to the experts, to the authors of the statement, to Tino, to Kuhn? If not, I'd like to point out, even if Kuhn said that it's difficult for many people to join the ERC Congress, of course, for those who will join the Congress, there will be a session on this topic also, where we will also discuss this further. And if you are interested in joining and collaborating for the upcoming second ILCOR statement following really a strategic approach, I would call it, then reach out to me. I will put my email address in the chat, and then we can talk about your involvement. Thank you everyone so much for your for having attended this meeting. Thank you to the experts who have shared their thoughts. I wish you a very good night, good morning, good day, wherever you are, whatever your time zone is. And I really hope that we can together address this in the future and find solutions. Thank you very much, and goodbye.